So when we talk about ACS, this is now an emergency. Like I said, there are three acute coronary syndromes. They are unstable angina, non-ST elevation MI, and ST elevation MI. How do we tell them apart?
Cardiac.
12-lead ECG and cardiac enzymes taken within 10 minutes of arrival. So here are the differences, one in each paragraph. So when we say unstable angina, there is reduced blood flow, there is rupture of the plaque, and there is a blood clot. However, the artery is not completely occluded. So this is the main difference between unstable angina from and STEMI and STEMI. However, can the patient who has unstable angina progress to an MI? Yes. So right now, it may be unstable angina because the clot did not completely obstruct the artery, but can that change? Yes, there could be another clot later that will obstruct the artery now and become a full-blown MI. So MI, same thing. There is plaque rupture and then thrombus formation. Now there is complete occlusion of the artery. So of course, what will happen to the myocardial tissue? It will die. Okay. Now, how much of it dies is the difference between NSTEMI and STEMI. I repeat, how much of the myocardium died is what separates NSTEMI from STEMI. Okay. So just like stroke, time is muscle. In the case of stroke, its time is tissue or time is brain. So time is muscle is for the heart. So there's urgency here. So the patient needs to have that artery open. Okay. We already discussed 12-lead ECG. Now, what are the changes that we will see? Now, if there's an MI, the patient will have a pathologic Q wave. Now, the Q wave is not usually discernible, meaning, yes, there's a Q wave, right, on the ECG rhythm. However, this one is a pathologic or an abnormal looking Q. This Q is really a really deep, a really low dip on the ECG rhythm. Okay, so let me show you what it looks like. So this is an example of an MI. So the rhythm ECG reading will look like this. Okay, so you see the ST elevation here. This ST segment is supposed to be isoelectric, right? It's supposed to be flat. Now it is elevated. Here are other examples. That's an MI also. Okay, so we have ST elevation there. And also on this 2-lead ECG, this time on lead V2, okay, also on V1. So it's not visible in 1, 2, and 3, but you see it in V1 and V2. So this is now the pathologic Q. You see the very low dip of the Q wave. So that's an abnormal Q wave. That's a pathologic Q. Then here's your ST elevation. There may or may not be T wave inversion.
So
See an example.
So this is with the MI or STEMI?
STEMI. I'm trying to show you and I did show you the pathologic Q. Okay, so that's what the abnormal Q wave will look like. Any questions? Okay. Manifestations as we described earlier, so no different from the associated signs and symptoms seen in angina pectoris and also in unstable angina. So same, because there is sympathetic stimulation here automatically. And as already mentioned, the signs and symptoms of MI cannot be distinguished from unstable angina. So therefore, they're collectively diagnosed under acute coronary syndrome. Plus also the fact that, yes, you may have unstable angina now, but will it stay like that? It may progress to an MI. Okay. So what's the difference between NSTEMI and STEMI? It's really depending on how deep is the involvement in the myocardium. Okay, let me show you NSTEMI. So you saw an NSTEMI, a STEMI ECG rhythm. Okay, so this is now what an NSTEMI looks like. See the difference? So earlier, this ST was elevated, yeah? In ST elevation. This time it is depressed. So now you have ST depression. So it's supposed to be isoelectric again. So if it was STEMI, then there will be a pathologic Q. So you see here, there's no pathologic Q wave. Okay? There's no low dip. So the Q wave is absent, but then you have ST depression instead of isoelectric and no ST elevation. So you have ST depression. As I said, there may or may not be a T wave inversion. T wave inversion usually appears in STEMI.
So what?
T wave inversion. Let me show you. Right here. So this inverted T wave here usually accompanies STEMI. This one, since there's no ST elevation here, this T wave inversion here might be old because that also stays in old MI. Patient has a history of an old MI. The T wave usually doesn't disappear, so it's permanently there. Here you have T wave inversion. ST elevation with T wave inversion in this. Okay, so let me describe NSTEMI and differentiate it from STEMI. So in STEMI, you have a pathologic Q, right? You have ST elevation with or without T wave inversion. So what this means is in the heart, in the myocardium, let's say it's in the left ventricle. Take just an example. Since let's say if it's a left ventricle, then that means it's the left anterior descending artery that is blocked, and the left anterior descending artery, coronary artery, supplies the left ventricle. So when you see this ST elevation, that means the entire thickness of the ventricle died. This whole thing here. the entire muscle is dead. Can something dead come back to life? No. So of course, there will be troponin elevation here, right? And troponin will remain elevated because the dead myocardium, of course, continues to release it. So that's a STEMI. In NSTEMI, since there is no pathologic cue, instead you have ST depression, like this. That means the MI is only this much. So a subendocardial infarction is what explains the ST depression. You don't have ST elevation because again, in ST elevation MI, the whole thickness of the muscle died, right? That's what's responsible for the ST elevation, meaning unlike here in ST depression and STEMI, this part of the muscle is still alive, correct? Okay, so these will still contract. This will still communicate. This will still transmit impulses. So there will be no ST elevation. However, it's kind of delayed. So you can say that the as the the sodium potassium channels open and close, yeah. So there will be a little bit of delay here in the influx, meaning what's happening during the ST segment? It is the early repolarization, yeah, because the T wave, the ventricles will repolarize, correct? That's why you have a T wave, and what's happening during the QRS? They are depolarizing, right? They are contracting. Okay, so in the ST segment here, they are, because this part died, so it will be delayed as to when the ventricle will repolarize. Does that make sense? Because this part died, so it will take a while before these cells here will repolarize. So you'll have a delayed, so there will be ST depression. Here, this will actually, because here, this section here does not repolarize at all because it's dead. So only these sections here will repolarize. As a result, there will be early repolarization. Does that make sense? Okay, so just to go into the technical part of it, why there's elevation here and there's depression here, that's the reason. All right. But in both cases, yeah, the heart died, part of the heart died. However, which one is more of an emergency? This one or this one? This one, of course, right? So this one, yes, the patient suffered a heart attack, but did it fully kill the myocardium? No. So therefore, which one is this really as emergent as this one? No. So here you can say that yes, the patient had a heart attack, but the blood flow was restored. Okay, so it didn't kill the entire myocardium. So therefore, as long as the patient stays as NSTEMI, we have a few hours to wait. Usually when you have NSTEMI, we don't take the patient to the cath lab right away. Unlike STEMI, wherein we have to do it now because otherwise it'll kill the whole thing, right? So we have to go restore blood flow. So otherwise not just this section, this whole section here will die, right? So we have to go take the patient to the cath lab right away because it won't stop here. It will spread to other areas, right? Especially if there are more coronary arteries involved. So let's say even if, yeah, this part here died, yeah, but we can still save the others. Okay, we can still reopen the others. Make sure no further death of myocardium happens. So that we have to do it right now. In NSTEMI, Yeah, it died like, yeah, a few minutes ago. Yeah, it caused death, but it stopped, meaning blood flow was restored. So we'll still reopen. The patient has a bad heart, okay, have bad coronary vessels, but we can do it in the morning. Does that make sense? Do you understand why? Why is this emergent? It's ongoing. It's ongoing. It's the heart is dying. Okay, it's killing more and more areas. So we have to take the patient to cath lab like right now. This one, yeah, it killed a few, yeah, like probably a few minutes ago, but it seemed to stop. Okay, there's no more, no, there's no ST elevation. So yes, we'll schedule this patient for PCI, but later, okay, during business hours. Okay, we don't have to do it right now. Does that make sense? Okay. So here are your illustrations. So you have here an inverted T wave. You have, so these are the characteristics of an MI. So you got inverted T wave, you have ST elevation, and then you have pathologic Q. So here you have all three, pathologic Q, ST elevation, and T wave inversion. So as already described, in unstable angina, will you see any ST depression or ST elevation? No. Will there be any um, uh, elevation of cardiac enzymes? No, because in unstable angina, nothing died. Okay, nothing died. What about in NSTEMI? Yes, there will be some troponin increase because, yeah, it killed some myocardium. And also definitely in STEMI, this will be very high. Okay. Normal troponin, by the way, is less than 0.012. I repeat, troponin levels is supposed to be less than 0.012. Now, there are other conditions. Did I mention this in shock? Okay, so in other conditions, other ischemic conditions, hypoperfusion conditions, let's say, good example is last week. When we talk about shock, whether it's septic shock or hypovolemic shock, there will be elevation of the troponin, not that high. So but otherwise it'll be positive. That you'll have numbers like 0.1, for instance, or 0.02. That is positive, right? Because it's over 0.012. So you'll have a slight elevation of troponin in shock, not because there's a heart attack. It's not caused by a heart attack. It's caused by hypoperfusion. Because remember, the MAP dropped below 65, correct? So therefore, can it cause tissue death? Yes, so at the myocardial level, it did injure some myocardial cells, but it's not because of a blood clot. It's not because of a heart attack. It's caused by hypoperfusion. So doctors document that as demand ischemia. No, just imbalance between oxygen supply and demand. So demand ischemia is responsible for the troponin elevation in shock patients. Are we clear? So we already showed the ECG changes. So this is the first thing you'll do. Of course, after you put oxygen first, and then give the nitro oxygen, and then put on the ECG leads. And then draw blood between CK and because there are three mentioned here. So we will draw troponin, CKMB, and myoglobin. Let's look at the timeline for these three because all three will be drawn. However, the most reliable remains the troponin. Okay, so just you can see, let's take a look at this drawing. The vertical axis is the value of the cardiac enzymes. The horizontal axis is time in days. This is not hours, this is days, okay? So meaning first 24 hours would be here under 1. You see, you follow? Okay. So the red is representing CKMB, and then the, what is this? Blue or purple? Okay, purple is troponin, and you have, we don't have myoglobin, but anyway. So you see here, two, one pale red and one dark red, one purple, one blue. Purple and blue are troponin, then you have CK here, light red and dark red. So that means which one rises first? As soon as myocardial cells die, which one rises first? No, CK rises first, followed by troponin. However, which one stays elevated? The CK or the troponin? Troponin stays elevated. So it's more significant, therefore, for troponin because plus CK, is this really cardiac muscle specific? No, other muscles in the body also produce CK. So, however, troponin is only released by myocardial cells. So therefore, it's the more cardiac specific, because CK, for example, can be influenced by, so let's say you're doing chest compression. So let's say this patient had cardiac arrest after the MI, then we did chest compressions, right? So you injured skeletal muscles along with the cardiac muscles during chest compressions, right? So it may affect the levels. Okay? Unlike troponin, troponin is not affected by CPR chest compressions. Okay? This is released exclusively by dead myocardial tissues, dead myocardial cells. And they stay elevated. Look how long they stay elevated until, well, without perfusion, this can stay elevated up to the 10th day. But the important thing here is a peak. Okay, so we need to draw, so these cardiac enzymes will be drawn every 4 to 6 hours, usually every 4. And we want to see a peak. Once it peaks, that means, are the cells still dying? No more. They stopped right here. So if it peaks here, our goal is for it to peak, well, great if it peaks within 12 hours. Okay, that means, did we reperfuse? Yes, that means, let's say you had a heart attack, you came to our hospital, we got you into the cath lab within 60 to 90 minutes. We got the balloon in there, we opened your artery, blood resumed, we got blood flow resumed to your myocardium. So it will peak, right, in 12 hours. That's great. That means if it peaks in 12 hours, that means did we meet our goal? Yes. Yes, because what's the significance of a peak? Let's say COVID peaked, right, in sometime, right, because unless you see a peak, what will you not see? Something going down. Okay, so because until you see a peak, it will keep rising. That means, are myocardial cells still being killed? Yes. So unless you see a peak, then that's never good news. Once you see a peak, oh, it stopped now. Okay, so we reperfuse. However, again, don't expect it to go to 0. It will stay elevated because there's dead tissues there. So they're already dead. So they will continue releasing troponin. However, it won't increase, right? Once it peaks, that means, are any more cells dying? No more. Only the dead ones stay dead. Okay, so the rest are alive. So now you'll see it steadily going down. Okay, so once it peaks, then that's good. Sometimes it will plateau. What is plateau? Like this. So we usually see plateaus in non-MI conditions. In, let's say, in shock, like I said. So in shock patients, we see elevation and then it plateaus. That's we confirm. Oh, this is a hypoperfusion issue. Okay, this is because of the shock in the patient. Let's say, especially if the patient has many comorbidities. Let's say cancer patient or very old. Okay, so they may respond poorly to antibiotics. Let's say we're talking about septic shock, right? So they will respond poorly. So they'll have a plateau instead of like this in an MI wherein it drops. Okay, Now, you can also have a second peak, meaning if this, you see a peak and then goes down and then this starts going up again, what's your explanation for that? The patient had another heart attack. Can that happen? Yes, that can happen again. Okay, especially with the complications for our procedures. Okay, we'll talk about that next. So protein, I already described. Okay, so there's troponin C, I, and T. So between the three, it's really T and I are specific, okay, to cardiac muscles. CKMB, I already described. Myoglobin is again not very specific. So here's our guidelines. And then the drugs, of course, is ONAM, together with beta blockers there. Now, the beta blocker is, of course, going to not only suppress the sympathetic stimulation, which is again automatically triggered, yeah, but also lower blood pressure in addition to ACE inhibitors. Again, anticoagulation and statin. Of course, statin is not given like during the acute episode. I mean, what's the statin gonna do, right? So we'll do that for the future, okay? Long-term therapy. We'll describe thrombolytic therapy shortly. Okay, so again, the goal of management for ACS is what? To restore blood flow, restore perfusion and oxygen delivery to the myocardium. So we already described ONAM, so that's ONAM right there, followed by what's next? ECG, yeah? And then don't forget the beta blocker, then cardiac enzymes, and heparin, okay, along with nitroglycerin. Okay, so since this is the gold standard, so we'll call the cath lab team. If it's wee hours in the morning, let's say 2 a.m., 3 a.m., we'll call them. So as soon as we expect the patient, let's say we get the call from the EMT that they're inbound, the staff will be called. And if you're on call, of course, you're expected to come to the hospital as soon as possible within a certain period of time. You only be put on call if you live within a reasonable, area from the hospital. I mean, it doesn't make sense, right? You're in Long Island and then your hospital's in Queens. I mean, I'm not gonna put you on call. You're useless, too far. Okay, so only the people who live within the vicinity will be called. I mean, it's just for practical purposes. If you insist, like I want some, some on-call pay too. Okay, then stay close. Okay, yeah, you better be here, right? So if the patient doesn't have PCI available, then your only option is thrombolytics. Again, we don't prefer thrombolytics as much as possible because of the dangers of hemorrhage. Patient could bleed to death. So for STEMI, this is our guideline. Okay, target is 60 minutes. Used to be 90 minutes, now it's 60. Hospitals will actually advertise this in their websites. Say NYP advertises, I think 30 minutes, unless I mistook it for another hospital. But yeah, they compete for your business. So where will you go? 60 minutes or 30 minutes? Where will you take your heart? I'll go to 30. Okay, I'll take your business there. I'll take my business there. Okay, so in the case of thrombolytics, so this option again, if there is no PCI available, so we're only left with thrombolytics. This should be done within 30 minutes of symptom onset. There is a table here for contraindications for thrombolytics shortly. For PCI, let's just focus on our responsibilities, okay? So until the patient goes to the cath lab, because of course, can we get them to the cath lab right away within 3 minutes? Well, unless it's during the day, right? The staff is there, but if there's no staff, because we have to get the cath lab ready for the patient. Okay, we have to get the team in. So until then that's what you will do. The one you did, you practiced today for Carl Shapiro. So you'll do the ONAM, cardiac enzymes, ECG, then beta blocker, and because it will take time, then you'll be running the nitroglycerin and the heparin. Understand? Okay. So sometimes if it's during the day and then we get the confirmation and then the patient is eligible for PCI, there's no time for the especially the nitro. Okay, so the patient maybe we have to have the heparin going because we don't want any more clots causing another MI. Okay, so here's the contraindication part if we choose the thrombolytic route. So here are your indications: chest pain lasting 20 minutes or more, ST elevation, and the patient is less than 12 hours from the onset, so they're qualified for thrombolytics unless they have any of these. So if you have active bleeding, known bleeding disorder all the way to pregnancy, can they have this option? No, PCI only. And these are your responsibilities. So if the patient does receive thrombolytic, these are your responsibilities. You'll see this again. This is not exclusive to MI. You'll see the same nursing considerations in stroke. So later for exam 2, we'll discuss stroke because ischemic stroke is treated with thrombolytics. So same responsibilities apply.
So what if we teach somewhere else, like they have one of these translations and there's no PCI?
I mean, what can we do? Sorry.
Just do it at the children's.
Yeah, so we'll explain, the doctors will talk to the family, explain just bad luck, okay? So we don't have PCI, patient can't get thrombolytics. Okay? So especially if it's absolute, there's relative contraindications not listed here, but absolute means absolutely not. Okay, so the doctor won't arrest their license when the patient has these. I mean, the patient could die. All right, this part we won't discuss. Rehab will be a long time. There's 2 types of rehab. There's inpatient cardiac rehab, and there's also outpatient. Outpatient, meaning the patient goes to the outpatient facility or they get home health, okay, rehab. But most patients after an MI are usually in a inpatient rehab. That's usually the choice of the cardiologist. Cardiologist will insist, I want inpatient rehab. It's only when the patient is, let's say, very stubborn, hard-headed, that the doctor has no choice but agree to outpatient. Let me just emphasize for rehab, our criteria really because sexual activity resumption is usually a frequent question or concern by the patient. So we usually do not based on time. Used to be long ago, we based it on time, but now it's based on the patient's activity tolerance, meaning if they can climb 2 flights of stairs or walk 1 block with no symptoms, meaning they're not short of breath, then they can resume sexual activity. Okay, because that's about the amount of energy you need, right, to perform sexual activity. Yeah, climb 2 flights of stairs or walk around 1 block with no symptoms. Otherwise, I mean, how are you gonna finish or even perform, right? Okay, let's go now to the invasive procedures. Okay, so if the patient is not a candidate for PCI, so here's PCI. And here are, after a heart attack, this is what you teach the patient. You have to change your lifestyle and then medication compliance, lose weight. Well, yep. So this is what you teach. Then don't forget the nitro, because they'll have prescription for nitro. So our goal here is when we prepare the patient, so let's say it's not STEMI. So STEMI, we can't really prepare the patient. We don't have that much time, yeah? So everything's really fast. So most of the pre-op teaching will be skipped, okay? Because we have no choice. We have to go right now. But if it's STEMI, we have all the time in the world. So we can do teachings, we can prep the patient properly. For STEMI, our preparation is the site, okay? Nowadays, not much preparation because we no longer use the femoral artery. During my time, it was the femoral was the preferred site because it's a big artery. So we had to clip the hair, okay, at the groin, okay. So because not the whole, don't shave the patient, okay. We only clip the hair, but only in the groin area. You understand? Meaning you don't have to shave them bald. Okay, so just in the groin area. So just clip the hair. I made that mistake. I was a new nurse. Nobody told me. Okay, and I didn't read the textbook really. So I shaved the patient clean. Okay, she was 80 something years old. And she didn't ask me until it was over. She said, "Is this really necessary?" And I said, "Yeah." So the less hair, then the less infection you get. She said, "Ah." So I was written up, long story short, I was written up the next day. I didn't get suspended or anything. I was just written up. And then it turned out that lady had multiple PCIs already. So she had it done. She didn't say anything. She just, okay, so just enjoy she could have said something. So in addition to balloon, they may leave a stent to keep the artery open. So that's an option. I'll skip through these because there's really doesn't concern us here. This is all the doctors show. Okay, so your number one responsibility is to, especially now that they use the radial artery now. So there's not much really we can do. We need to do. We just do teaching about what to expect, what happens if it's the radial artery. They're in and out. They go to the cath lab. After the procedure, they come back to your floor. Their activity is up ad lib. If you feel good, go walk around. Okay, so no more bed rest because it's the radial artery now. During my time, it was all femoral, so the patient was on bed rest, and then because of the bed rest, what complications will happen? DVTs, okay, and then pressure ulcer. So we stopped that. Okay, so we said, nah, not bad idea. So they now can do it through the radial artery, which is perfect. Okay, patients ambulatory afterwards. Very few complications. So here's their post procedure. So your monitoring, of course, is can the patient have another MI? Yes. So you monitor the patient for that. Continue with the medications, okay, and monitoring. Patient will be on a cardiac monitoring floor. Watch for dysrhythmias because of the procedure, and of course the site. Okay, like I said, the radial artery is now used, so very few problems with bleeding. In the case of the femoral, right here, this term here called femostop, that's pronounced femstop. Just put the O silent. Okay, femstop. So it's a C-shaped clamp, like this. It's more like a half. It's like a bowl. Bowl, a small bowl. Um, and there's a strap on the top of the bowl, goes around the patient's waist, and you tighten it using blood pressure set no, the bulb. Yeah, like press it until it tightens, and then because otherwise you'll have to be doing manual pressure on the femoral artery. Now nobody can do that. Okay, so we use this device to stop the bleeding. And we did quite a lot of these. It was a hassle because you had to monitor the femoral artery, the popliteal, because we wanted to compress the femoral artery only to stop the bleeding, not to occlude blood flow. Because otherwise, if you compress it too much, then there will be no blood flow to the leg. Okay. And here are your complications. So another MI could happen, bleeding. No, this is site specific. It could be bleeding in the retroperitoneum, arterial occlusion from a clot, pseudoaneurysm. This is not really an aneurysm. This is like a hematoma. Okay. ABM, AKI. What type of AKI is this? Pre, intra, or post-renal? In a PCI. This one. What type of AKI can result? Pre, intra, or post? Pre, or it can also be intra. Intra because we use a IV dye during a PCI, okay? Because otherwise, how will you see the coronary artery without an IV dye? You understand? Meaning, can you see it on X-ray, on fluoroscope? You can't see that. So we have to inject a dye so we can see where's the balloon now? Where are we going? Okay. So you can't see where the doctor can't see where he's going unless there is an IV dye. And that IV dye can cause AKI, intrarenal AKI. Okay, last topic is CABG. So if the patient has triple vessel disease or more, PCI is not practical. So we're better off bypassing the coronary artery. Triple vessel disease, meaning more than 3 coronary arteries are involved, meaning it's a mess, okay? So more than 3 coronary arteries are blocked. I mean, how are you gonna do it? So we'll go to the big branch and then bypass the whole thing. These are the indications. Alleviation of angina cannot be controlled medication or PCI. If it's the left main coronary artery, and again, multivessel CAD. Or we tried PCI, but we couldn't do it. So now we have CABG. Now the graphs that will be used can either be a vein or an artery. If it's a vein, then it will be the saphenous vein, or it can also be the perineal vein. Yeah, but the biggest vein will be saphenous. So they'll use that. The vein harvest procedure is also easier now. Used to be we will cut the patient's leg from groin all the way to the ankle to harvest the vein. That was the traditional. Now we have modern techniques, so we can do endovascular harvesting now. So we'll just make 2 incisions on the leg, let's say one above the knee and another one at the ankle, and then pull the vein. Can you picture that? Okay. Now, like this. So instead of cutting the whole thing from here to here to expose the vein, they'll just cut here, make an incision here, and then once you cut the vein, then you'll pull it. Okay. Don't worry about the vein. There's other collateral circulation, so blood flow will continue through other veins. Okay, it's not like this is the only vein in your leg. It's several. Okay, so again, so we don't do this anymore. No more of the long leg incision, so small, just a 2 inch, sometimes 1 inch incision, depending on the surgeon. So you'll watch the harvest site. Okay, that's one of your post-op sites, your surgical sites. And then you can also, let me just describe the bypass. So once you have your vein, so they can start the procedure now. So they'll lay it on the table. So they'll cut it into the appropriate length that they need. Okay, so they'll cut the vein because there may be more than one bypass that's needed. Okay. So basically, there are, depending on which hospital you go, so now they can do bypass graft procedure either with a beating heart or the traditional non-beating heart. Because a non-beating heart, that means you have to divert the blood flow. So the patient would be placed in a heart-lung machine, divert the blood there. So your patient's blood will be pumped and oxygenated by a machine. Okay, circulation will continue. However, the heart stops. Okay, and then they'll do the bypass graft. They'll attach the graft vein or the artery, and then later restore blood flow, put it back. Because you stop the heart, the patient will have pacemaker leads because it'll take time. So once the procedure is finished, they'll put pacemaker leads inside. The pacemaker, of course, will be outside the body. And then because you cut through the pericardium, there will be bleeding in there, correct? So you'll expect a drain there. You remember chest tubes? Okay, so this one is a mediastinal chest tube. So a smaller tube in the mediastinum. So you expect three things to be there: two pacemaker wires and one mediastinal chest tube. Okay, and it'll be attached to the same box, chest drainage system we talked about last semester. Okay, so same box. However, will there be any fluctuation in the water seal chamber? No, because this is not the lung. Okay. The doctor can also use, so instead of a vein, they can use an artery. They can use the the mammary artery. Mentioned somewhere here. I can't find it. Anyway, if it's the internal mammary artery that's used, usually that's you expect more blood loss in that because you have to pluck the artery, and once you pluck it out of the mammary muscle, then that will cause some bleeding. Okay, so you expect more bleeding if it's the mammary artery that's used. The choice really is dependent on the patient's age, a few other factors. The doctor and the patient will discuss it. Okay, which one is best? Of course, the younger patient, which one would you use? Say 40 or 50-year-old patient, or even in their 30s, which one's better, a vein or an artery? An artery, because you expect them to live longer, so that would be one of the factors to decide on an artery. Or it could also be the internal thoracic artery, whichever one's best. So here's the picture now. So once you have complete bypass, that's what it will look like. So this one is an artery though. So this one is using the mammary artery. Okay, so they plucked it out of the chest, put it into the coronary. Make sense? Because otherwise, if it was a vein, then it would be not. Of course, not. It's not attached to the aorta. It will be right here. Okay, so from the aorta here, lower part of the aorta, into the coronary vessel, whichever area is blocked. And again, this part is not testable because this is the doctor's show. So a patient will induce hypothermia. You will learn about hypothermia, therapeutic hypothermia ACLS, when you go for your ACLS, we do this in the ICU. Okay. Let's go to your post-op responsibilities. So let's start with and here are the complications. So you should watch out for after surgery. So this is part of your post-op care. So watch for blood loss. Again, AKI will be listed here. Cardiac tamponade, what would be a cause for tamponade here? If what is one of the tubes that's left in place? A mediastinal tube, yeah. So if those mediastinal tube is blocked by a blood clot, for instance, what happens to drainage? Drainage will stop. What happens to the patient? Cardiac tamponade. So here, fluid and clots accumulate in the pericardium, compress the heart, cardiac tamponade. What are the 3 signs again of cardiac tamponade? Beck's triad. What was that? Muffled heart sounds, hypotension, and irregular veins. Very good, children. So stroke can also, just like basically any other post-op patient, okay? So they can have another heart attack, a stroke, a PE, or AKI as well, pre-renal AKI. Okay, post-op. So here are your responsibilities. So you care for the incision site. Watch for complications as listed in that table. Make sure the patient has SCDs, okay, subcontract compression devices, okay. The decision whether or not a patient will be placed on heparin, of course, the doctor will decide. If you do work in these units, it's like a hotel, okay, a 5-star hotel. These are suites. They don't do bypass in some sorry ass looking unit. Okay, these are advanced suites like Waldorf or Astoria level. Okay, that really like Ritz-Carlton. Okay, nice, Plaza Hotel. These are nice suites. Okay, they have good views because there's a lot of money involved here. Okay, before you can have this procedure, of course, the doctors will make a lot of money. Okay, so they want the facility to be really nice. They design it that way. Okay, so nice suite, butler service. No, it's the nurse really who's the butler. Okay, you give them a lot of pain meds. Okay, make sure the patient's comfortable because they're after the survey. Okay, survey. How was your care after the procedure? Because what will happen if you had poor care? No good pain management, dirty area. What will you put in the survey? And then what will happen when they tell their friends who needs a bypass? Don't go there. Okay, so they want the business, so has to be wonderful. Okay, a very enjoyable experience. Okay, considering. So if you want to work, see, because this will be cardiovascular ICU. Yeah, that's a good unit to work in. Okay, very good staffing. You have like 1:2. Sometimes 1:1, depending on the day. This here, you of course monitor the patient's hemodynamic status. Okay, watch again for complications, especially cardiac tamponade. Pneumonia is another frequent complication in addition to DVTs. Right? That's it for ACS. Any questions?